the main message and the main takeaway message is that we have to be very careful and start treating our patients early. Meaning that when a patient is symptomatic, the diagnostic workup must be very careful and complete, so to choose the best option for therapy, because we do have options. And even starting from what we call the best supportive therapy, we have to listen to our patients, because the level of hemoglobin, that is the anemia, may be perceived in a very different manner according to the subject and the different persons. So if, like Dr. Buchstein presented, if a patient feels that his or her hemoglobin is low, even if for our standard is not as low as we think, we should treat. And this is a very important message that I think we have to deliver both to patients and to doctors. Of course, too many transfusions that sometimes are necessary can be detrimental because of the iron accumulation in the long run, and therefore we also need to think about getting rid of iron with the iron chelation therapy that is now available and working. So it's a very complex, even a very simple approach like transfusion is in fact quite complex and should be followed up very carefully. And this was the, let's say, the very first message. And then the other talks were focusing on actual therapies. The options are available, and there is also the possibility through the study that have been conducted until now to have a good option for each patient, because we may have sequential therapy, start with the type of drug or agent that is more, let's say, ideal for the patient in that specific moment. But the patient can respond very well and then lose response. And I'm talking especially about anemia, because we have more drugs that are targeting this cytopenia than other, like thrombocytopenia or neutropenia. So we may start by treating a patient with erythroid stimulating agents, and then we can, when the patient loses response, we may choose another therapy like luspatercept, following which we can use another drug that is imetelstat. I try to give an algorithm with a sequential therapy and the choices that can be made. Of course, you need to evaluate several characteristics and several criteria that can help in choosing the therapy, the burden of transfusion, so the number of transfusions that the patients receive, the disease history, other characteristics like the level of hemoglobin, the serum EPO level, and this will drive our choices as doctors. And then the follow-up and the, I would say, the feedback of patients on how they tolerate and how they feel, so their quality of life, but not only that, is extremely important. And you know, there are some patients with low-risk MDS who do have not only anemia, but also other cytopenias. And in these cases, Dr. Garcia-Manero presented data indicating that hypomethylating agents can be really important. And important also not only because the counts are improving, but also because overall survival is improving. And we had exactly the same when treating successfully with ISA, with luspatercept, and also in part with imetelstat. So we do have several options, and we have to use them. I do think that, as I just mentioned, there are many drugs, many agents available, but what is very important for the future is to characterize molecularly all these cases, because we may have target therapies that I didn't mention because they were not presented today, but there are. For rare cases, for more frequent cases, we do have some drugs that can target the specific mutation. And we start having evidence in that sense as well. And what I think will be the future is to identify more targets and more alterations that are possibly targeted by drugs. I do think that transplant is also a therapy that should be considered in lower risk MDS. Not all lower risk MDS will be eligible, and there is a balance on pros and cons on the issue of receiving a transplant. Of course, is the only curative options we have for MDS, even for low risk MDS. But again, the risk related to transplant has to be considered, as well as the molecular risk of a low-risk MDS. Sorry to repeat it, but it's very important that the discussion is open and is started from the beginning, from the diagnosis. It will require maybe years to be performed if it's a real low-risk MDS, but we do have to consider this from the beginning with our patients.